Good morning. Welcome to the Department of Medicine Ground Rounds. Every year we come to celebrate the life of Dr. Towery, and we'll describe a little bit about him and about what was going on at the time of his birth and history, which I think has important implications. But before that, remind everybody that Match Day was a little over a week ago, and I believe that you have received an email with the photographs of our new class of residents for next year, which we are very proud of, and we're excited to get them in and see what they have to offer, and also to educate ourselves with these new incoming students. I also had the opportunity on Tuesday to go to Shaker Village, which every year, second-year residents from the Department of Medicine at UK and U of L come together in Shaker Village for a couple of days where they discuss cases, they talk about career options, they learn about Shakers and a couple of other things, but they also drink some beer, have some good food, and then engage in something called Medical Jeopardy, where they actually compete with each other for knowledge in medicine. And I'm told that, again, I want to say it nicely, we won in a big way. So congratulations to the residents and Barbara and Jen and the rest of the team over there. Now, Dr. Towery was born in 1915, and there were interesting things happening at that time, just a little over 100 years ago. And at that time in 1911, on this day, was the birth of Bernard Katz. Sir Bernard Katz, was a German-born British physiologist who learned about neurology. And by that time, it was known that neurons produce acetylcholine. But it was Dr. Katz who really figured out that neurons were producing acetylcholine continuously when neurons were at rest. They were packaging them in things called vesicles. And that these vesicles were released as mediators depending on the electric potential of the axon of these neurons. And for that, he won the Nobel Prize in 1970. A little over 100 years ago was also the birth of Cyril Dean Darlington, who worked on chromosomes and heredity. And he understood by the work of Morgan that chromosomes actually overlaid upon each other and switched information. And he developed this theory of heredity and evolution that were very much dependent on this transfer of information from chromosomes, which we take for granted today, but in those days was not well understood. And by that time, in 1901, X-rays were known. Why? Because in 1901 was the first Nobel Prize for Physics given to Dr. Wilhelm Röntgen for the Röntgen rays, also known as X-rays. And he was born on this day back in 1845. So this was all going on in the early 1900s when Dr. Beverly Towery was born in 1915 in Kentucky. He spent his life in southern Kentucky. He went to Western Kentucky State College. After that, he went to Vanderbilt University to obtain his MD in 1940. He did his internship there. He went to residency in pathology at the Mallory Institute of Pathology at Boston City College. And then he was assistant resident physician in medicine at the Mass General, where he met a lot of interesting people, but particularly Fuller Albright, who was born in 1900, well known for his work in parathyroidism, the McCune-Albright syndrome of dysplasia, renal tubular acidosis, osteoporosis, and that had a tremendous influence on him. And then 2 years he spent at the Thorndike Memorial Laboratory at Boston City Hospital, where he met Robert Williams. And anybody who does endocrinology has had to look at the textbook, the Williams textbook of endocrinology. So as you can imagine, tremendous influence for Dr. Towery to become an endocrinology, and he did. And we were lucky enough that in 1956 he was asked to come to Louisville to become the professor and chair of the Department of Medicine. He was very well known for his efforts in education. He was very well known as a terrific teacher, and he brought in a significant number of highly qualified but also enthusiastic faculty who were also terrific educators on their own, and did a great good for this organization and this department. In 1970, Dr. Towery stepped down to become chief of endocrinology and spend more time to his passion, which was the bedside and bedside teaching. And unfortunately, a few years later, he developed a viral encephalitis, which we never quite recovered from that, and died in 1981. And his family and friends and colleagues came together to put an endowment assemble an endowment so that we remember him and all these things that have happened in the area of endocrinology since his birth in 1915 and his efforts in educating doctors in Kentucky and the region. And for that, every year, the chief of endocrinology brings someone who's very well known in this field to talk to you about new things that help us understand better our craft. And for that, I will bring you Dr. Steve Winters, who's going to talk to us and introduce our guest of today.
Thanks, Jesse. Certainly a pleasure to have as the Towery visiting professor this year, Dr. Larry Frohman, who's the professor emeritus and a former head of medicine at the University of Illinois in Chicago, and prior to that, chief of endocrinology at the Michael Reese Hospital and at the University of Cincinnati. And Dr. Frohman has been very active in many societies of endocrinology, including the Endocrine Society and the Pituitary Society, of which he was its president. And he has been on 13 editorial boards and presently associated editor of Translational Medicine. Dr. Frohman's research career has included both basic and clinical investigation and is focused on the physiology of growth hormone deficiency and its excess in acromegaly. He was among a group of investigators who initially identified and discovered growth hormone releasing hormone, and he has co-authored over 400 publications and was co-editor of one of the endocrine textbooks, Endocrinology and Metabolism. He's been a member of many NIH study sections and clinical trial data and safety boards. His NIH grant entitled Neuroendocrine Control of Anterior Pituitary Function was funded 5 times. And he continues to publish, and yesterday he talked with us at Endocrine Grand Rounds about a relatively recently identified syndrome, familial isolated pituitary adenomas. And today he will discuss a relatively uncommon disorder, acromegaly, but a fascinating syndrome because it affects almost all of the tissues throughout the body, and every subspecialty of medicine has some connection to acromegaly, I think. And he will today discuss his lifetime experience as an acromegaly researcher and patient care provider. Thank you very much.
Okay, this is working. Thank you very much, Dr. Winters. It's really a pleasure and a privilege to be here and to join the list of very eminent endocrinologists who have been former speakers at this annual talk. And I must say that I've had a tremendously enjoyable day here yesterday with the endocrine division and being capped off today with this presentation. I'm going to say I had to show you a picture to begin with of what my city is supposed to look like, although for the past couple of months the bottom half of the slide was all white. And the lake has pretty much thawed now, so I think hopefully spring is on its way. This is a list of my disclosures, which there are a limited number there. And to start off with, I will abbreviate the comments that I was going to make about Dr. Towery because they were so elegantly described, although I will mention just one thing that I noticed that I came across as I was looking through the internet, and that here is a picture of Dr. Towery when he was a resident in training at Vanderbilt, as you can see, one of the younger looking people who still had his hair. And the one other person who I would mention here who was a director of the house staff training program at the time, and I'm sure who influenced him, was Tinsley Harrison, who went on to have his own very fantastic career as a cardiologist. But this was quite a group of individuals, and you've heard the rest of Dr. Towery's history and made many contributions and had interacted with a number of very exciting people in the course of his training experience. Now, some of the old in acromegaly really goes back to historical times. And the first good evidence that there was this disease was present comes from a stele that is present in the German State Museum in Berlin of the Egyptian pharaoh Akhenaten. Now, there is some controversy as far as whether he did have acromegaly, but I think the point is that here he had a very prominent jaw and thick lips, and a number of scholars believe that was indeed the case. Now, this goes back to 1300 BC. If you want to trace it back even further, there is some data that was recently uncovered that talks about the origins of the disease prior to that time. And so this was the first acromegalic giant that had been identified, and as you can see, that he was well preserved. But the disease has been noted through the Middle Ages, and of course was finally established by Pierre Marie in the 1880s, who first described the disease and called it by its current name, and was identified due to a tumor in the pituitary gland. Now, coming up a little bit closer to present time, let's talk a little bit about where and how frequently we see this disease. You heard it mentioned as a rare disease, and I guess it really does fit that category. But there are some very good epidemiologic studies that all come from Europe. Unfortunately, we don't have the kind of a healthcare system in this country that allows for this kind of data registration. But from these studies in Europe, we come out with evidence that there are about 3 to 4 million new cases per year of acromegaly. The prevalence has varied in studies anywhere from about 26 to about 200, an average of about 60 per million per year. As far as the prevalent, that shouldn't be per year, but 60 per million. The age of diagnosis of this disorder is an average of about 45 years, although it can certainly be seen starting in the late teenage years, where gigantism is a major component, and it sometimes is not diagnosed until late into the 60s or 70s. The mean age of death of patients with acromegaly is about 20 years later, and so this is a foreshortening of about 10 years or more in terms of the lifespan as compared to the expectancy in the normal population. The causes of death are nothing unique, but it's basically cardiovascular, cerebrovascular disease, as well as a respiratory disease. The one thing that is of constant concern to all of us interested in this disease is this bottom statement, which is that the mean interval from the first symptom to the diagnosis at the time that these studies were initially put together was 7 to 10 years. Some more recent studies say it may be more in the terms of 5 to 6 years, but even so, that is a long period of time and allows for many of the symptoms to develop before the disease is actually recognized. One comment about the etiology of this disease. We do know, 99+% of patients with acromegaly have a growth hormone secreting pituitary adenoma. There are rare examples where there are other causes which the disease may be attributed to primarily overstimulation by the growth hormone releasing hormone stimulus, but 99% are pituitary adenomas. And if one looks for molecular basis for the disease, the one predominant finding has been mutations present in the growth hormone releasing hormone signal transduction pathway. Just to review that very briefly, growth hormone releasing hormone, after binding to its receptor, activates a stimulatory G protein stimulating adenylyl cyclase, eventually release of cyclic AMP, which ends up causing a dissociation of the regulatory subunit of protein kinase A from the catalytic unit, which ends up phosphorylating Krebs and affecting many different genes that result in somatotrope proliferation and eventually tumor formation. And depending upon the series, anywhere from 25 to 45% of patients with acromegaly, their tumors show one of two mutations that are present in this GS protein, both of which turn out to be activating mutations. So it appears as though there is constant activity, constant stimulation, and these are mutations that are somatic mutations that occur in individual cells which eventually lead to tumor formation. There are a few other defects that are present in some very rare examples, entities where acromegaly may be traced in familial disorders to specifically other genes that I talked about yesterday. But for all intents and purposes, it is primarily this GS protein that has been most commonly observed to be mutated in patients with acromegaly. Now, just a general comment, which is that in order to try to reduce the time from the onset of the first symptoms or the first signs of acromegaly, the diagnosis really depends upon the physician having a high index of suspicion. And frequently, the endocrinologist is asked to confirm a diagnosis, and the patient with some other type of healthcare provider has referred for evaluation, such as an orthopedist or a neurologist, because of things like carpal tunnel syndrome. Sometimes an otolaryngologist will see the patient, or a pulmonologist, all of which ends up, rheumatology is a very common source of referrals. And so that, again, it's usually when a new physician sees the patient that the diagnosis can be suddenly thought about and established. And would emphasize that the most helpful information in terms of the history of acromegaly in a patient can come from photographs and objective measurements of ring and foot size. And this is something that we all do in terms of asking patients to bring in photographs. And many of these now have been described in textbooks where you can see the gradual progression. And when family members see the patient on a daily basis, this is never recognized until somebody new comes into the picture. Now, by the time the patient is diagnosed, there are a series of clinical features, and you can see the frequency in various reports. I think the most common, of course, are the enlargement of the hands and feet and the coarse features that are present, increased perspiration in women, menstrual abnormalities, and headaches. Those are the most common. Then there are others that are characteristic of the disease that are primarily the overgrowth of the bone and joint and soft tissue with the arthritis and carpal tunnel syndrome. Approximately a quarter may have impaired glucose tolerance or diabetes, and then some of the others that are listed here are seen less commonly. But the whole question is that it is primarily the features that can be recognized by observing the patient that will lead to the diagnosis. Now, in terms of making the diagnosis, this has changed a bit since we first began to be able to measure growth hormone more than 50 years ago. I point out the fact that growth hormone is secreted in a pulsatile manner, so that if you look at growth hormone levels in a healthy adult and follow them over the course of a 24-hour time period, there are pulses, there are spikes of growth hormone, frequently up as high here is about 15. They may, in a young person, may go up to 25 or 30. And these values are the same. These are the values in an acromegalic patient. The point of this slide is to say that you cannot, from getting a single growth hormone sample, manage to distinguish a patient with acromegaly unless you have extraordinarily high values. And what was described originally was the glucose suppression test for acromegaly, and this goes back now, again, 50 years and has stood the test of time over this half century, which is that normal subjects given a oral glucose load will end up having a suppression of their growth hormone levels down to virtually undetectable values, whereas as patients with acromegaly either will not suppress or will only have partial suppression. And this still remains one of the gold confirmatory tests for diagnosing acromegaly. Subsequently, it was recognized that many of the effects of growth hormone are mediated through the formation of other proteins, particularly insulin-like growth factor 1, IGF-1. And one of the advantages of measuring IGF-1 in circulation is that it is not pulsatile. It's fairly stable through the day. And it turns out to be a very good discriminator for patients with and without acromegaly. And in this study, which came from David Clements at North Carolina, they showed that they had a complete separation between patients with acromegaly and normal subjects. It's not always that clean, but this has become now the preferred simple single value to obtain in screening for patients. Again, I would point out that to make the biochemical diagnosis of acromegaly, remember that the single measurement of growth hormone is not an accurate indicator of the true elevation, since the secretion is pulsatile, and random growth hormone sampling results in both false positive and false negative results, so that a single growth hormone is really a waste of time. Patients can have active disease even though growth hormone levels fall within the normal range, because the normal range, which your laboratory will tell you is from 0 to 10, it doesn't mean very much for a pulsatile hormone. A hormone that's secreted in a pulsatile manner can be deceiving. And the diagnosis, as I mentioned, is confirmed by the failure to see growth hormone suppression. And we keep dropping the level. It used to be less than 2, then as the assays improved, it went down to less than 1, and now the feeling is that the growth hormone levels have to go down to less than 0.4 in order to be able to exclude the disease. And turning to the IGF-1, again, it's a measure of the average daily growth hormone secretion, and interestingly enough, the patient's signs and symptoms sometimes tend to be much better correlated with IGF-1 levels than with growth hormone levels. The levels remain stable through the day. They're unaffected by meals that can be obtained at any time, and they're a good indicator of disease severity. But it's important to remember that the linear relationship between IGF-1 and growth hormone tends to disappear as there is a maximum level to which the IGF-1 levels will rise no matter how high the growth hormone levels are. And finally, as with any laboratory test, it's important to remember that the normal range is defined statistically. And that statistic is basically the 95% confidence limits, which means that there are going to be 2.5% of normals who have a low IGF-1 and 2.5% of normals that have a high IGF-1. And so that this is something that has to be kept in mind. And finally, the range of the IGF, the normal range of IGF-1 is age-dependent. It's not gender-dependent, but it is age-dependent. And what is normal for a 25-year-old could very well be in the markedly elevated range for somebody who is 65. So that this is important to keep this in mind. Now, in addition to using these two measurements for defining the disease, it has also been recognized that this shortened lifespan and increased mortality of acromegaly is influenced by just how well and how effectively the patient is treated and how well the growth hormone and IGF elevated levels are brought down to normal. And in a series of patients, it was shown that if you looked at the growth hormone levels at the age of diagnosis and at follow-up, and looked at a group of individuals that had survived their disease compared to those who had died from the disease, you can see that those whose growth hormone levels had been brought down into a low range had a much better chance of surviving than those whose last growth hormone level who had died, whose last growth hormone levels tended to be elevated. So an argument for why it is of value to bring the level down. And similarly, now data is coming out with IGF-1 levels, looking at IGF-1 levels at the last follow-up of patients. And if you look at the observed to expected mortality ratio, you can see that in those individuals whose IGF-1 levels are within 2 standard deviations, which is normal, the observed to expected ratios are relatively normal. This is listed as one would expect in a non-acromegalic population, slightly elevated as the IGF goes up. And those who had raised IGF standard deviation scores had a marked increase in their IGF at their last follow-up. So again, this has been the impetus toward very active treatment of patients with acromegaly to try to restore the life expectancy to normal. Now, with this as the underlying background, the question then comes up and becomes obvious: what are the treatment goals for the disease? As was obvious, we're talking about controlling growth hormone hypersecretion to get a random growth hormone down to less than 2.5 nanogram per mil. This is not completely normal, but from the best of the data available, it appears that if you can get down to this level, you can probably restore normal life expectancy. Again, reducing IGF-1 levels to age-corrected normals. You want to relieve the symptoms of the patient has. You want to remove or at least reduce the tumor mass of their pituitary tumor. If they have visual field defects, of course, we want to try to correct or at least improve them, preserve pituitary function. And this has become a big factor now because it's not a question of taking out the pituitary, it's a question of getting rid of the adenoma and preserving the remainder of pituitary function. If there are hormone deficits, of course, we want to prevent this and to treat it. And as far as preventing or alleviating comorbidities, this is something which is also taking a lot of interest today. It's important to remember that the bony changes that occur with acromegaly are not reversible. The soft tissue changes are reversible. And one of the major complaints that patients with acromegaly have is that of multi-joint arthritis. Generally, the large joints, very typically this appears like osteoarthritis, but at a much earlier age. And once this occurs, it's very difficult to do anything more than just treat them symptomatically, so that early treatment becomes very important. Well, from this, let's go into the various modalities that we have for treatment and how these have evolved over the years. Surgery was the original gold standard. And the first successful surgeries for acromegaly actually go back to the relatively early 1900s and the 1920s with the eminent neurosurgeon Harvey Cushing, who actually was able to control patients with acromegaly. At this point, it was primarily by removing virtually all of the pituitary gland. But surgery has remained the gold standard against which all other therapies have been compared. And it has improved with the various techniques that are available, with the endoscopic surgery. But the point is, I think the surgery has now probably reached its zenith, in that the amount of success rate that one has surgically has not really improved in the past few years. This is not being critical of the surgeons, but it's because of the fact that the technique can only go so far. Here are some recent series, surgical series, chosen because they all represented very considerable numbers of patients. And these are all published within the past 10 years or so. And if you look at patients that were considered to be cured, and by this we're talking about growth hormone and IGF levels down into the normal range, there was a very great distinction. And the tumors, depending upon whether they were microadenomas, defined as being 10 millimeters or smaller in size, or macroadenomas larger than that. And with the exception of this one series, you can see that we're running in the 80 to 90% cure rate in the microadenomas, and we're running much less than that in the macroadenomas, particularly if the tumor extends beyond the confines of the pituitary. And unfortunately, about 75 to 80% of patients with acromegaly have macroadenomas, so that the overall success rate tends to be more in this range than in the 80s to 90s. The second important point to make here is that the skill and experience of the neurosurgeon is critical to success in terms of treating this disease. This was an interesting observation made among British hospitals by Stephen Shallett, a very renowned British endocrinologist, who talked about the percent achieving normal growth hormone levels at various hospitals. And you will see that there is quite a bit of variation from under 20% going up to about 65 to 70% in a series of a dozen hospitals in the UK. And the important thing here is to recognize that one, to get optimal care, should find a neurosurgeon who is at the tip of the funnel, who sees a lot of patients, who has good experience, and that is the best chance. The first operation is the best chance to try to get the patient cured. There are some tumors now that are not going to be able to be cured by surgery, no matter how good you are. This MRI shows a large pituitary tumor present here on the sagittal section, and here on the coronal, you'll see the large tumor filling the pituitary. These are the carotids, and there's this extension into the cavernous sinus. This kind of a tumor can never be cured by surgery. You just cannot get this tumor all out and still not run the danger of damaging the carotids. So that the question is, what are the indications for surgery in these large, invasive macroadenomas? Well, certainly if the patient has visual field defects, the patient does require surgery, and that is without question. Sometimes you may have other major compressive symptoms and very huge tumors, such as hydrocephalus. Relative indications are minor visual field defects. Sometimes these are not really the cause of doing the surgery, but if the patient has persistent headaches or hypopituitarism, that may be a reason to go after removing even parts of the tumor. There have been a number of reports now that patients who have developed hypopituitarism primarily because of compression of the normal pituitary by the gland, some of these patients may actually have a reversal of the hypopituitarism, and so that is a hope that surgery may be useful. However, probably the major reason for going after large tumors, even if they cannot be removed in entirety, is there is now good evidence that if you debulk the tumor, you can improve the response to other treatment modalities, both to medical therapy and to radiation therapy, and I'm going to go into this a little bit more detail. So the question then comes up with the second modality of therapy. What about radiation therapy? Which patients should be radiated? Now, radiation therapy also had its early onset in the 1940s and had been a mainstay of therapy. It is beginning to change now for reasons that will become obvious. But patients whose symptoms and hormonal testing indicate that they still have active disease, despite surgery and today, despite medical therapy, are good candidates for radiotherapy. If a patient has intractable headaches, or if they have significant cavernous sinus extension and they do not respond to medical therapy, radiation is used. And particularly in patients who have evidence that there is continued tumor growth, even while they're on medical therapy, are candidates for radiation therapy. Now, initially, radiation therapy was carried out with conventional fractionated therapy using 3 different ports, about 27, 28 treatments over 4 to 5 weeks. And more recently, the radiotherapy with computer modeling has improved its ability to focus the beam on the pituitary, fewer treatments, and fewer adverse effects in terms of surrounding structures. Currently, the treatment that is used most commonly is what is called stereotactic radiosurgery. I'm not sure that I like the term radiosurgery. It's stereotactic radiation using a gamma knife or a linear accelerator or a proton beam, but there's no surgical incisions made. These are just very well-placed radiation beams, and this can be carried out in 1 or 2 treatments. The important thing, despite the love affair with the newer techniques, is that there are no good comparisons of the results among the types of radiation, and they probably will never occur because of the fact that people have given up on the standard technique wherever they can use these stereotactic techniques, and what we can do is make historical comparisons. Other important thing is that this does not change the problem with regard to one of the adverse effects of radiation, which is loss of pituitary gland function. Now, looking at fractionated radiotherapy, of course, the major reason for the therapy is to try to control the tumor growth, and you can get biochemical control at about 50 or 60% of patients, depending upon the series, from 6 to 8 to 10 years. So this is slow-acting therapy. Remember, the effects of radiation are on dividing cells, and this being a benign tumor with a relatively slow turnover rate, the effects do require a prolonged period of time. And that's one of the major disadvantages, is the delayed response to the therapy. Hypopituitarism is something that is unfortunately present, and if you look at 10 years, there will be a deficiency of various other pituitary hormones, most commonly the gonadotropins, but both TSH and ACTH will occur. There are no good ways to predict which patients will lose the therapy or lose these pituitary functions, or when the functions will be lost. There are rare secondary tumors that have occurred as a result of radiation therapy, gliomas, sarcomas, but with improved treatment techniques, these are becoming extremely rare. And you must be at a reasonable distance from the optic chiasm, because otherwise radiation of the chiasm can lead to visual field defects. Now, moving over to the gamma knife therapy, two recent studies have shown reasonably good results. They have, in this particular study of over 130 patients, they had a normal IGF present at in about 50% of patients. The time to remission is shorter than with the standard radiation therapy, and this is its one advantage, in that here was a mean of 2.5 years for patients to have normal growth hormone levels compared to the 6 to 7 years. The new hormone deficiencies, unfortunately, turn out to be no different than with standard radiation therapy. And consequently, the technique, although it is used now, still has the same limitations that were seen in terms of the previous therapy. The one thing the radiation therapy will do is, of course, will decrease the tumor volume, and this has been probably its major use. Here 90% of patients were able to have their tumor size decrease with radiation therapy. There are some tumors which tend to be relatively resistant to radiation therapy, and the tumor will increase in size, and these turn out to be major problem cases to deal with. Well, the rest of the time I want to spend talking about the kinds of pharmacotherapy that has become available. And this really changed the field beginning in the mid-1980s. There are 3 classes of drugs which are now usable in patients with acromegaly. The first, and this is historically, were the dopamine agonists. And this is because the first drug useful for treatment any type of pituitary tumors was bromocriptine. We'll get into the second generation, which is cabergoline. And there's a third drug, quinagalide, which also turns out to be useful, although it was never introduced into the United States and is currently available in Canada, but not in this country. The most commonly used drugs are the somatostatin analogs, and here is somatostatin, the natural inhibitor of growth hormone, and these are all long-acting analogs which have been used. The predominant drug is octreotide in its short-acting and long-acting repository form, and then a second drug, lanreotide. And then more recently, a different concept, which is the growth hormone receptor antagonist, pegvisomant. And there are some advantages and disadvantages to each of these agents. To start off with the dopamine agonists, as I said, they were the first one used. Bromocriptine was a drug that was initially available, and it really was not terribly effective. They were able to normalize in the studies only about 10% of patients had normalized IGF-1 levels. We'll skip over the quinagalide. Cabergoline, which was the second generation drug, seems to be considerably better. Obviously, both of these drugs work through dopamine receptors, which are present on the tumorous somatotrope cells. About a third of the patients can have their IGF-1 normalized with cabergoline. And this is cabergoline given in combination with other drugs where one can get up to perhaps 50% improvement. So that the drug has some use, although nobody is terribly happy with even a 30% normalization of IGF-1 levels. Now, what was recognized is that, remember that the dopamine agonists used primarily for treating prolactin-secreting tumors, and many growth hormone-secreting tumors causing acromegaly also secrete prolactin. So you have a combination, a mixed secretory pattern. And this goes back to the cell of origin, which is frequently what's called the somatomamatropa cell, which secretes both growth hormone and prolactin. And it was found that there was a greater response when you had a tumor that was producing both growth hormone and prolactin than in those that were pure growth hormone-secreting tumors. But to turn that statement upside down, it says that just because a patient does not have co-secretion of prolactin is not a reason to avoid trying cabergoline. It can be useful. The other thing, and I mentioned this earlier, is that there is a greater response when the initial IGF tends to be lower than when the IGF tends to be higher, a very dramatic difference. And this goes back to why some people advocate debulking by surgery to bring the level down prior to treatment. The same is true for the initial growth hormone level. When it's less than 20, there is a better response rate than when the level is elevated. And one can see tumor shrinkage by the use of cabergoline primarily in the growth hormone and prolactin secreting tumors. So this is about as far as the cabergoline and the dopamine agonist story can be carried out. As I said, the major drug used is somatostatin receptor ligands. And in order to understand this, let's just look for a moment at what somatostatin, the natural inhibitor of growth hormone secretion, does. Somatostatin binds to one of 5 different somatostatin receptors, and through both GI and GO proteins has inhibitory effects on potassium, calcium channels. It inhibits adenylyl cyclase formation, decreasing cyclic AMP, decreasing protein kinase A, and phospholipase C. All of these are important intermediaries in decreasing hormone secretion. However, the other part of the action of the somatostatin relates to its effects on cell replication and growth. It stimulates phosphotyrosine phosphatases. It enhances apoptosis. It inhibits mitogen-activated protein kinase, MAP kinase, and this results in a decrease in cell proliferation. So we have both of these effects of somatostatin and, as we'll see, of the analogs that are important in controlling growth hormone secretion and the size of the pituitary tumor. Now, there are 2 drugs that have been developed that are available in this country now and in most of the world. The first, historically, is octreotide. The second is lanreotide. Here is the molecular structure of somatostatin, a 14 amino acid peptide with 4 critical amino acids for receptor binding. And what was done very cleverly is to change one of those from an L amino acid to a D amino acid, which has a major effect in preventing a breakdown of the product in the bloodstream. And whereas an intravenous injection of somatostatin has a half-life of about 90 seconds, the injection of octreotide or lanreotide has a half-life in terms of several hours. So these are now useful pharmacologic agents. The comparison of these 2 drugs, lanreotide being the newer drug, show that they're very, very similar. If you look at the percentage of patients with growth hormone or IGF that have been normalized or both, these numbers are not statistically different, and so that they really one has no advantage over the other, except lanreotide can be given by deep subcutaneous injection, whereas octreotide requires intramuscular injection, and this drug is more amenable to be given by the patient's partner or a friend than octreotide, which usually has to be given by a healthcare professional. Now, as with the effects of dopamine agonists, the pretreatment growth hormone is a predictor of the response to octreotide. You start with patients with pre-growth hormone levels, pre-growth hormone levels that are greater than 50. The normalization is only about 30%. As the growth hormone level drops further and further down to levels of less than 7.5, you will get a much higher level. So again, arguments for trying to get the growth hormone level as low as possible by other means before starting the treatment have been advocated for this particular reason. Now, going back to the somatostatin receptors that I mentioned, there are 5 somatostatin receptors that are present in normal pituitary tissue, primarily on somatotropes, but also on corticotropes and other pituitary cell types as well. In growth hormone secreting pituitary adenomas, 4 of these 5 receptors are present. And the predominant receptor types are type 2 and type 5. And it turns out that both octreotide and lanreotide end up being primarily type 2 somatostatin receptor analogs. And as you can see by this, and one looks and measures the somatostatin receptors in pituitary adenomas and looks to see how effective octreotide is in suppressing growth hormone levels, it turns out that the major difference, if you compare the difference between more than 50 or less than 50% suppression of growth hormone levels, it doesn't make much difference as far as somatostatin type 1 or 3, or not very much in 5. But somatostatin type 2, this happens to be one of the variants of somatostatin type 2 receptor, shows that if you have abundant somatostatin type 2 receptors, you can get a very dramatic suppression of growth hormone levels. In the absence of somatostatin type 2 receptors, you don't, and these are the so-called somatostatin analog resistant patients that are more trouble to deal with, and we'll get into that in a moment. Now, with all this, the question has come up, well, what about treating patients primarily with medical therapy rather than surgical therapy? As you know, this is certainly the change that has occurred with treatment of prolactinomas, and the question is, can this be applicable to patients with growth hormone adenomas? And if you look at patients that have normalized their growth hormone levels and IGF-1 levels, a decrease in tumor size, you can see that as primary therapy, and certainly in patients who have the low likelihood of success from surgery, you can get a fairly good reduction into normal levels by just giving octreotide alone. So therefore, primary pharmacotherapy is being considered now in patients where the likelihood of a surgical cure is less than 40%, and these are primarily patients with large tumors that extend into the cavernous sinus or into other regions of the peripituitary region, patients who are poor surgical anesthetic risks, and there are some patients who are very adverse to the idea of surgery, and they can be a candidate for the use of primary medical therapy. The natural corollary of that is, what about if you treat medically? Is this going to improve your chances of getting the pituitary tumor successfully removed? And there are a couple of papers in the literature now. The largest one comes from China with a group of about 40 patients. And the take-home message on this slide is that if you pre-treat the patient with octreotide, and these are usually 3, sometimes 6 months of pre-treatment, they have an improvement in the reduction in growth hormone levels to a normal range. And now we're moving, excuse me, I have to get used to this thing. We're moving to the patients with lower levels than 1 nanogram per mil, normal IGF-1, or both are normal. And it appears that in patients who have, these are particularly in macroadenomas where you would expect your success rate not to be very great, they were able to improve the surgical outcome. This needs to be confirmed in other studies, but it is becoming a very attractive hypothesis to use. All right, moving on to the growth hormone receptor antagonist. This was an accidental discovery. The receptor antagonist was discovered by manipulation of the growth hormone molecule by a scientist by the name of John Kopchik, who was trying to find a more perfect alpha helix in the molecule and to make a super potent growth hormone agonist. It turns out, however, that he came out with a growth hormone antagonist effect. Just thinking about growth hormone and its mechanism of action, growth hormone binds to a growth hormone receptor, which is a dimeric growth hormone receptor. The two growth hormone receptors bind to different binding sites on the growth hormone molecule. The two receptors then coalesce on the cell surface. This preformed growth hormone receptor dimer results in activating of JAK2 kinase, and functional dimerization occurs, and this results eventually in the production of IGF-1 and other effects of growth hormone. What has been done by the modification of the one amino acid that impairs binding to one of the receptors, receptor site 2, and substituting other amino acids, they have ended up with a non-functional growth hormone receptor which blocks the signal transduction mechanism, and therefore you have a growth hormone which is ineffective. Even though the levels are elevated, you do not have effects there, and you end up with a decreased production of IGF-1. And when this drug is given in large doses, you can see that IGF-1 levels will drop from the pre-treatment values shown in the upper circles to values in the lower circles, which are, after looking at age-adjusted IGF-1 levels. In the original study, they said that 97% of patients had normalization of IGF-1. But what's in parentheses is important, at least on one occasion. This doesn't mean that it's been always low, and in practice, it probably is about 75 or 80%, which is still a higher percentage than one sees with octreotide, but not completely normal. One concern has been that this is a drug which doesn't affect the primary cause of the disease, which is a pituitary tumor. You're just blocking the effects of the growth hormone. And although most of the mortality and morbidity is due to the growth hormone, you still have the pituitary tumor to be concerned about. There was worry that this allows the tumor to grow unchecked. And the question is, will this allow the tumor to create problems? In looking at a group of 100 patients or so, it was seen that if you look at the change in the tumor volume in terms of centimeters, the vast majority of tumors did not show any growth, whether the patients had been radiated or non-radiated. There were a few who did have growth in the pituitary tumor. We had one such patient that we reported, and it was a relative problem. The question is this due to pegvisomant? The answer is really uncertain. We don't know whether it was due to the introduction of pegvisomant, or more likely it may have been due to the cessation of octreotide therapy, which the patient had been on beforehand. But it's important that this is monitored in patients who are just on pegvisomant therapy alone. Now, the question is, what can we do for patients that are somatostatin resistant? And I mentioned that this is seen in some patients. One can increase the dose of octreotide, but that's infrequently helpful beyond a certain level. You can debulk the tumor to try to improve the response. You can add cabergoline. If the patient is close to being normalized, cabergoline addition will help. Or you can add pegvisomant, and then you finally have radiation therapy if it's not been previously used. And one of the interesting observations are patients who did not have normalized growth hormone levels treated with somatostatin analogs when pegvisomant was added rather than substituted. These patients all had the growth hormone levels down into IGF-1 levels down into the normal range, and it is a very useful combination. I would just mention that you can't measure growth hormone in a patient given pegvisomant because this is a growth hormone analog, and it basically is detected in the growth hormone assay. But what you're looking at is the IGF-1 levels. Even if growth hormone levels don't come down, you're not worried about that if the IGF-1 level comes down to normal. Now the rubber hits the road today. How much does it cost to treat these patients? And the data on this slide should be evident. One drug which has come off patent is cabergoline, and the cost for a year of therapy is a little bit less than $2,500. You start multiplying that by 20 to 30 times when you get up to either the octreotide or the lanreotide or the pegvisomant. So we're dealing with therapy which is quite expensive, and therefore there is reason, this is one of the reasons why I like to try cabergoline. Even though the success rate is not high, the cost differential is great. These prices, I don't know what they are in Louisville, but this is what I got out of the websites looking at the best discount prices in the Chicago area just earlier this month, and this is expensive. Now, there are a number of investigational drugs, which is where I'm going to end up, that have been used in an attempt to try to improve therapy. There was a drug, because I mentioned there are dopamine as well as somatostatin receptors, so a chimeric drug was made, dopastatin. Unfortunately, in clinical trials, has turned out to be not terribly effective, and that has been withdrawn. But there are octreotide implants, there's pasireotide, and octreolin, and I'm going to mention them just very briefly. Here is an octreotide implant, which is shown down in the bottom here. It's a relatively small implant that's put in subcutaneously, and it lasts for 6 months. Studies have shown that it is just as effective as octreotide long-acting by injection. This drug has gone through clinical trials. At the present time, the company has chosen not to try to move toward final approval, and I'm not sure what the outcome will be, but right now it is still considered investigational. The one interesting new development in the somatostatin analog field has been the drug pasireotide, previously known as SOM 230. This drug binds, shown here, it's a little bit different than the other two analogs. It's an octapeptide in a ring cycle. And if you look at the inhibitory concentration, of course, the lower the number here, the more potent the drug is. This drug is a little bit better than octreotide on somatostatin receptor type 2, but markedly better on somatostatin receptor type 5, where it's even better than somatostatin alone. And it's felt that some of those tumors that don't respond well to octreotide could very well respond to pasireotide. And so this drug is still investigational for acromegaly, although, as most of you know, it has been approved for use in ACTH-secreting pituitary tumors, which do have predominantly somatostatin receptor type 5 that's present. And in a recent study comparing the effect of pasireotide as compared to that of octreotide, either overall, post-surgical, or de novo patients, it seems to be better than is octreotide in reducing IGF-1 levels. And the other important point is if one looks at tumor reduction, there is a decrease in the tumor size in the majority of patients. And the important point is that this can be seen even when the growth hormone levels are not completely suppressed. So what this, again, points out is the two divergent pathways of somatostatin analogs. One is on the tumor suppressor effect, the other is on growth hormone secretion. Although they are generally concordant, they don't have to be, and you can get suppression even without, you can get tumor size suppression even without reduction of growth hormone levels. Now, another drug that is in the late stages of development is called octreolin, which is an oral octreotide. And the company that is making this actually has found a transient permeability enhancer, which allows the drug to be absorbed through transient defects created in the epithelial barrier in the intestine. And it has therefore opened up a new field of therapy. The prototype drug that they were studying was octreotide. And as you can see, if octreolin is given orally and 2 hours later there is a stimulus given for growth hormone secretion, the growth hormone levels are very markedly blunted by the presence of octreotide. And if one looks back at the early stages in the blown-up a portion of the slide here, there's even a reduction in basal hormone levels. Now, their phase 3 study has been completed. It's going to be presented at the Endocrine Society meeting. I'm not at liberty to discuss what the results are, but I can give you an idea of what they are by saying that Roche has just purchased the drug and is spending a considerable effort now to try to get it ready for marketing if it is approved by the FDA. So suffice it to say that this is an option. It is taken twice a day by mouth, and it represents another option. If a patient does not respond to octreotide, they're not going to respond to octreolin. And then finally, there are several other drugs that are in earlier stages of development. One is called somatoprim, which is another multi-somatostatin receptor drug. There are multiple other somatostatin receptor drugs in development. There is an antisense to the growth hormone receptor, again, sort of working to serve like pegvisomant. And the one that I just want to mention is this drug SXN 101742, which is a completely different concept. The growth hormone secretory granules fuse with the cell membrane and are released under the influence of a protein that's called a snare protein. And what it turns out is that botulism toxin can be a disruptor of these snare proteins. So what has been done is a targeted secretion inhibitor in which the heavy chain of the botulinum neurotoxin has been linked to the growth hormone receptor as a targeting agent. This now interrupts the snare protein and inhibits secretory granule fusion and release, so that this is in the very early stages of development, but it represents something that is a newer concept in terms of therapy. So, in summary, treatment today for acromegaly. In the patient that has gone through pituitary surgery, and if the growth hormone and IGF are normal, we monitor the patient. If the levels are elevated, we'll try somatostatin analogs with or without a dopamine receptor agonist. If the patient has full biochemical response, they are then simply monitored. If they have no biochemical response, we move to a growth hormone receptor antagonist. If there's a partial response, we may use a combination of these drugs. Again, if everything is normalized, we monitor the patient. If they still haven't responded, then radiation therapy comes into effect. This algorithm has changed on a yearly basis, and the slide is a relatively short half-life because it's always being modified. But I think as time goes on, we'll see more in terms of therapeutic abilities pharmacologically to treat this disease. And it's been an exciting field to watch the development over the past couple of decades. Thank you very much for your attention.
Thank you, Dr. Frohman. That was excellent. I have two questions for you. One is relates to that slide from the Lancet paper showing that the tumor size didn't change much with treatment.
Yeah.
And I was going to ask you if growth hormone or IGF or both affect the growth of the tumor directly.
This has been a question that has been raised, and there is no evidence that growth hormone itself will affect its own tumor growth. There's been a lot of concern about whether growth hormone itself has oncogenic potential. And among the many things I didn't get a chance to talk about is, of course, there's an increase in polyps in the colon. In patients with acromegaly, there was some thought that there was an increase in colon cancer. This has not been the case. There does seem to be a slight increase in other types of neoplasia, and this may well be under the influence of growth hormone. And as you know, there's considerable data in the literature looking at spectrum in normal subjects of IGF-1 levels in circulation and the likelihood that this may be increased in patients either with prostate or breast cancer. But we don't find a very high incidence of associated neoplasia in acromegaly, so it's not a major problem.
The second question I was going to ask you is more related to the industry. So if you mentioned that the prevalence is fairly small, about 16 per million. So in the United States, there are very few cases. And yet there's a lot of drugs being developed. And I'm used to seeing a lot of diseases that are considered rare diseases where industry does not pay attention to them because they can't generate a lot of dollars. Is it suggested that these hormones have an impact. You already said that maybe not in cancer. So tell me, what else is the industry looking that has led to so much investigation in this area?
Well, the question of where growth hormone or growth hormone excess might be causing other diseases. Of course, the one thing that has attracted many people has been the possibility of diabetes-related disorders, and particularly diabetic retinopathy. And of course, we're now talking a completely different kettle of fish in terms of volume of patients that could be affected here. But there is good data that growth hormone and IGF can increase retinal vessel proliferation. And the attempt to try to reduce this with drugs is something that I think is going to be very much sought after. Of course, the way to go after getting a drug approved, of course, is to pick a rare disease. One gets orphan status, and this means that there's a longer patent protection. And it turns out to be the way that all of these drugs have been approached by the pharmaceutical manufacturers. But obviously, when there are almost as many endocrinologists as there are patients with acromegaly, you're not going to find an awful lot of marketing capability there.
Yeah. Questions? Yes, sir.
All right, let me deal with the first one is easy. No, there is. I'm sorry. Let me talk about that. Can one measure somatostatin receptors in tumors from individual patients? Commercially, there is no laboratory that is doing this. These are all on the basis of research capabilities. I suspect we're a few years away from this, and it will be possible to do it. But presently, no, you can't do that, and we just end up looking at the response right now to see how well the patient does with the octreotide or the lanreotide. Now, as far as the danger or the risk of danger, of course, it was now, must be about 5 or 6 years ago that the 2 papers appeared in the New England Journal talking about the development of cardiac abnormalities, particularly valvular fibrosis in patients primarily with Parkinson's disease, treated with dopamine, cabergoline dopamine agonists. Studies in patients with prolactinomas have not shown any risk of these cardiac abnormalities, and there are now a few series that have come out with acromegaly, again, showing no particular risk. The numbers are relatively small, maybe 100 or 200 patients are not enough to be able to solve that, but the doses are lower, and this has not been a problem, so that although we were initially rushing to get ultrasounds on the echoes on all patients in whom the drug was being started, that has now pretty much gone the wayside, and we're sort of going back to our old practices.
Last question? If not, we want to send you home with a gift from Louisville, the Louisville Slugger. Dr. Lawrence Frohman, 2014, Beverly Tower Lecture, University of Louisville, March 27, 2014. Thank you for coming. Wonderful lecture.
Okay, thank you very much. It's my pleasure.
We'll send it. Did you drive or did you fly?
No, I flew, so I'm going
to... We'll send it to you.
Okay, I was going to say.
You don't want to try to bring this in there.
I don't think they'd let me in. Even though I don't look like a terrorist, they probably...
They'll hold you back. Trust me. We started this 4 years ago, and I called from the airport, and they said, okay, don't worry about it. We'll get someone to pick it up.
Okay, thanks.